This morning I want to talk about the course overview beginning here with week one to orient you to some, I guess you might call housekeeping regarding the course. So I wanted to look at the modules. You'll need to use the modules each week to work through the course because I list everything, I link everything to the module that you will need each week in order to complete the various tasks. I've shown a picture here of the first week modules. I may do some minor fixing of this, but in week one you'll notice that there's an introduction and overview section. Every week you'll find weekly notes that outline exactly what you're expected to do that week, and then I've listed everything on the website here that includes what your material would be. In week one there will actually be two academic journal entries, one around the introductory ideas or overview of the course, and then specifically material on Scott Miller's research, which is associated with the International Center for Clinical Excellence. So as you see on week one, you'll want to download the SRS and ORS client feedback or therapist forms. Those are forms that you can use in therapy with clients that are evidence-based linked, and that you elicit the client's input at the end of each session as to how successful the client perceives the session to have been. I've also attached articles that support Miller's work. Particularly two articles that help norm the instruments that you're going to download. And then at the end of week one, you'll notice that I have legal and ethical issues because that's part of the material for the week, and I've just added some videos that would be of help to you. You'll notice that in week two it's not as dense, so some weeks will have more material than others, but pretty much week two will stay the same as I've put it up here. There's the weekly notes, my PowerPoint lecture, which isn't uploaded here yet, but it will be. So there will be two links for the lecture. One will be the lecture itself, which has the video like I'm doing now, and then under it will be one without the video that you can download for your study. And with that, I've linked two videos that I suggest that you look at, and then I will every week at least have a few articles that associate with what we are talking about. So in week two there are actually 4 articles that I have uploaded to the site that you can click on and read over. So moving then to the first week of the course, we're going to look at theory, methods, evidence-based practice, curative factors in practice, the ideas around critical thinking, which are certainly at your graduate level, ethical implications for practice, and an overview of the course. So what is theory? Case theory explains the behavior of one person, so one case it suggests. Mid-range theories explain a set of cases or events, and the grand theories attempt to explain all sets of events and cases within the province of the theory, whatever the parameters of the theory would be. What is a practice theory? Practice theory consists of, it's a subset of theories, but it's limited to perspectives on interventions with individuals, families, and groups, particularly in reference to social work. It's a coherent set of ideas about human nature, including concepts of health, illness, normalcy, and deviance, which provide verifiable or established explanations for behavior and rationales for clinical interventions. So you'll see there's a circular kind of process between theory and practice. Practice frameworks provide a framework, for instance, to predict and explain a client's behavior based on where they're coming from and what your interventions may lead to, generalize among client and problem areas, bring order to intervention activities, and identify knowledge gaps about practice situations. A lot of times in practice, you'll encounter clients that don't fit easily within any particular theoretical framework, which challenges you then to, I think, become eclectic in terms of how you approach the client. And as we look at the development of theories over time from Freud forward, we'll find that people do different things based on their worldview in terms of how they see people and the world and their interactions, and how they might want to respond to helping them. For instance, if Freud's psychoanalytic theory doesn't seem to be exactly on target for their approach, you'll notice as we look at various people over time how they've segued into different ways of helping people, all of which may have potential for success in solving issues that come to them in practice. What are social work methods? Social work methods are specific types of interventions and other activities used by social workers in their professional practice. Specific methods may include social casework, social group work, community organization, administration and social work practice, research, policy, planning, direct clinical practice, family and marital treatment, other micro-practice settings related to the clinical social work practice, uh, which is called generic, and then there's an area called generic social work practice, which combines both macro and micro practice elements. One might look at that as perhaps a holistic approach where one not only looks at the mental health issues, but again, the client in the context of their life space, which is very important each time you're working with clients to keep that perspective, whether you're doing clinical or casework management, whatever you're doing. Having that broader perspective, I think, sometimes links you to possible answers to issues that clients are presenting. So here we want to look at the relationship between theory, method, or model. Theories are abstract concepts that suggest to the social worker which intervention strategies may be effective with clients, whereas the method itself is the concrete action taken by social workers to help clients achieve their goals. A method, for instance, may be like the empty chair technique, which Fritz Perls developed in Gestalt therapy, where he has a client sit in a chair and speak to an empty chair that represents the person they're wanting to encounter. And a conversation ensues where the person in the chair makes comments to the visualized person, and then the client moves to the chair and speaks back to themselves about how they believe the person that they're trying to address would respond to them given what the nature of the conversation is. It's a very healing kind of process, but it would be considered a method, in other words, to deal with processing forgiveness or understanding or whatever else the client may be trying to experience at the time in relationship to the other person. And then practice model. These are guiding strategies for working with certain types of clients. For instance, cognitive behavior therapy is something that's used a lot with people who may be more concrete in their thinking, and others as well, depending on which population we're looking at. It's used a lot with substance abuse clients as an example. Then what are the functions of theory? To simplify complex phenomenon. In other words, to have a plan in order to address issues that are somehow over time used consistently that suggest positive outcomes. It establishes a causal relationship and predicts influences on clients' future behavior. For instance, if you're dealing with someone with PTSD, and it involved an explosion perhaps. If the person experiences loud noises, they may respond similarly to the experience itself, thereby understanding it as kind of a causal relationship. Loud noises, the bomb, or whatever have an association which negatively impacts the person's perceptions at a particular time. And again, simplifying tasks by selecting intervention outcomes. In other words, taking the most simple and understandable approach that the client can relate to. Guide choices among intervention options, protects against irrational procedures. And that's important because it's in practice, you don't want to be doing something that has no previous practice evidence that it has any effect. Because one of the things that we adhere to in our ethics is to not harm clients. Therefore, we have to use procedures that are somehow showing an outcome that's effective. Then mobilize sound interprofessional practice and promote some generalization among clients. So evidence-based practice, what is it? Treatment outcome studies justify a certain treatment approach for a particular disorder. In other words, this particular approach has worked with these thousands of people. Therefore, it suggests that it would be effective perhaps with your client who fits into the uh, parameters of those clients where this method has worked consistently over time. And what evidence do you have that your proposed intervention will be effective with your client? And this is really an important aspect, especially if you ever are called to a witness stand about something that you had done. It's best that you can support what you do with evidence-based research, which you can cite to point to what left you to, or what led you to do the particular intervention. In other words, what is the rationale for utilizing a particular method or approach? And then the evidence-based practice, there are different models. This is one I've gotten off of the internet. It talks about the best research evidence. That's an important element here that we just talked about. And patient values and preferences. So what I like about social work is we encounter the person in their environment. Therefore, any specific method may not be the only approach that will work with the client, but you may have to become what we say more eclectic in terms of addressing the unique characteristics of the client in terms of what their needs are to reach some resolution to the issues they bring to you in practice. Issues related to incorporating evidence-based practice in your own clinical practice. Social workers must be skilled in person and environment assessment and diagnosis. So this biopsychosocial spiritual work is very important because it sort of is the foundation of what you're going to build on when you're working with your clients. Evidence-based practice must be adapted and personalized for clients based on their culture, interests, and circumstances. Perspectives of consumers and professionals must be taken into account in developing practice agendas. And this is really important when we look at Scott Miller's work because he gives you those forms where you can elicit your client's input at the end of a session to determine whether or not you've hit the target in terms of what the client's needs are and what you've been doing has had any effect in terms of the client's situation. Must take into account complex presentations and settings, and must have broader knowledge of intervention than being able to implement specific evidence-based interventions. So this suggests that when you're doing an intervention, it's most helpful to look toward where it is leading. In other words, if you're doing this, you're doing it for a purpose. Is the outcome that you're putting this together for or around fit with what you're attempting to do with the client? Then the best research evidence is important, clinically relevant research that you will look at. And practice expertise. The social worker's reliance on accumulated skills in assessing each client. So it's important to continue to develop your skills through continuing education and other opportunities. Social worker values the social worker values the preference and expectations that each client brings to the professional encounter. Again, client self-determination is a very important element to always keep in the forefront of our consciousness when we're working with individuals, families, groups, even in communities. Then looking here at research, effective social workers adjust theories and practice to fit the client's presenting problem. Also, you're looking at the client's character, their disposition in terms of how they approach the world, and what best fits in terms of your approach that will help them come to some positive resolution to their issue. Properly orient the client to the intervention. Very helpful to explain to a client before you're doing an intervention what it involves and what they may expect in terms of outcome. Specify purpose of selected interventions. Attend to time limits, very important. If you're going to have a 50-minute hour, then in 40 minutes or 45 minutes at most, you want to begin to look at having the client reassess how you've done during the session and how specifically how the client has done in working with you. Those are important things each time. At the beginning of each session, reviewing what has happened in therapy up to that time and then proceeding with the next level of what you're working with. Those are two good things to keep in mind as part of your time spent with the client. And again, provide active interventions that engage the client and all of their senses in the learning process. Focus on client change and to look at changing the behaviors. Again, structural frameworks change target systems. Again, criteria for well-established treatments include at least 2 group comparison experiments that demonstrate efficacy in terms of superiority, that is, of the particular treatment. So you'll want in your research to know that there have been numerous articles and studies around a particular method or approach. However, you may find also in the literature there's mixed reviews in terms of the success. Sometimes it's more based on the kinds of populations that are being the focus of the treatment as opposed to not everybody having some positive response. But you want to make sure that what you've decided to use is some level of testing over time. A series of at least 9 single-subject experiments demonstrating efficacy, use of treatment manuals to maximize specificity. I'm not wild about treatment manuals because I think it somehow constrains practitioners in terms of their eclectic approach to treatment. However, evidence-based people seem to sing this mantra. Perhaps it's more about being able to sell your product, because if you produce a manual, then you're going to charge for it. However, manuals do have their importance in terms of having a standardized way of approaching a particular issue. So there's arguments on both sides of this, I believe. And so if you're using a manual, I mean, I think that there's an ability to do some of your own use of self in practice as well as whatever the outlines within the manuals are. Clearly described characteristics in terms of the treatment and demonstration of effects by at least 2 different investigators. So you want more than 1 or 2 investigators that have used the method over time to see how they view how aspects of it are working or don't work with certain client populations. And then here we're looking at the association between theory method and evidence-based practice. So on the left here we have theory as it impacts evidence-based practice. Practice comes from theoretical ideas about how certain behaviors and treatments will affect a client. And then on the other side, you're looking at the method that might be used with the client and or the relationship of the therapist. Scott Miller, as we will look at in a few minutes, contends that it's not a method that has much effect in terms of outcome, but really the relationship that's initially established with the client by the practitioner. He contends that the method really doesn't matter, but the relationship is the key element in terms of success. However, when you look at evidence-based practice research, you'll probably not find the relationship. I added that to this because I think it's a critical element that we sometimes overlook in terms of working with clients and wonder sometimes why people don't come back after the first session. But that relationship involves engagement of the client not only in the therapeutic experience, but also, as I was saying, at the end of the session, asking the client what worked, what didn't work, and how they might suggest what may happen in the next session. So involving the client in their own process is a very important element. Next, we look at what are considered curative factors in all practice theories. The relationship with the practitioner is certainly a critical element, and the first. If you don't establish rapport, you're not going to have much success in working with individuals. And chances are, not only will they not benefit from whatever interventions or methods you're using, but they may not come back after the first or second session. You want to set a safe environment in which the client can talk about whatever it is that they're concerned with, and then understandable rationale and procedures that include an optimistic view of human nature. So if your understanding of human nature is positive or optimistic, the client will pick up on that, as opposed to someone who expects that all people will do the least, perhaps, or having a negative perspective on human nature. And then also active participation of the practitioner and client. This is a critical element in terms of working with the client. So in talk therapy, how can you engage the client more than just the verbal conversation? What can you do perhaps to engage the client in some sort of activity or practice of some sort of behavior that you're working with? Again, I'm wanting to talk about Scout Miller. I think in the last 10 years, he's probably the most important researcher that I've encountered. He suggests that practice outcomes are not better today than they were in 1976. And from 1998 to 2007, Miller says that there was a 35% decrease in the use of psychotherapy services and a 75% increase in the use of pharmaceuticals. So now there seems to be more of a focus on drugs than on therapy. Although I think indeed a combination of both can be beneficial for many clients. Miller and his colleagues decided to observe therapists and explore competent practice, and such success did not appear to be associated with practice models or methods. Erickson determined that successful practice was determined by what the therapist did before and after the session. So there's been a lot of studies over time about in-session and out-of-session elements of one's therapeutic practice. Miller talks about deliberate practice, and this is an important element here that I don't think we want to lose as we go through the semester. Miller asserts that the deliberate practice was the most important element to improve therapist skills. Practice is defined as when the therapist engaged the client during the session. So that's what practice is. Deliberate practice, as Miller discusses, is defined as the preparation the therapist makes when not in the therapy session. It may include reflecting on one's work after the session, planning for the next session with the client, or practicing therapy skills. These are critical, deliberate practice activities that enhance and strengthen one's ability to practice when in session with the client. Deliberate practice may involve studying the basics of therapy more. In other words, reviewing what you already know to kind of anchor that more deeply into your psyche, so that when you're working with clients, it really becomes something that's second nature. And then practicing engagement skills, to name a few, particularly how do you deal with a client in the first session? How do you establish rapport? Getting that down is really the first and most important element of working with clients in terms of your therapeutic practice. Curative elements in all practice theories. Common elements of practitioners that Miller, Duncan, and Hubble, his colleagues, identified as effective were the development of the therapeutic alliance. Again, very critical what happens in the first hour of your encounter with the client. How do you set the mood? How do you develop the rapport? How does the client know that you really care about what's going on with the client? And then the practitioner's ongoing attention to the client's perspective about the intervention. So at the end of the first session, you've used an intervention with the client, and the client in the rating form says that it was not very comfortable for him or her. What else might you consider doing in the next session? So you might elicit from the client, what was it that made you uncomfortable? How might I have done something differently to have made you more comfortable in wanting to talk about this particular issue, or made it easier? So you want to engage the client very much in terms of the process, not to assume what you're doing is working, but asking the client, is this working for you? Very important. Then there are curative factors accounting for therapeutic outcome. 40% are client characteristics in terms of what the client puts into it and takes from what you're doing. 30% is the therapeutic alliance. See, this is a really critical element of the success, is the client's confidence in you and has the sense that you really care about what's going to happen for the client. And then 15% he suggests is the guiding theory that one may use, and 15% is placebo effect. Curiously, you don't see a lot in here about the method or the model, and neither does Miller in terms of the research that he and his colleagues have discovered. I've also uploaded something from Lambert onto the site here off the internet, where he looks at a similar kind of discussion. And the model and technique, you'll notice, is considered at 15%. Placebo effect is 15%. But therapist relationship, again, here would be 30%, and the client's extra-therapeutic factors, for instance, what they might do with what you're offering them as they go out during the week and come back, those are elements that are really important in looking at practice and the theories associated with that. Selecting theories for practice. A good theory for practice should be coherent. In other words, can you understand it, and is it understandable when translated to your client? Is it useful with the practitioner's current clients? So do your clients' population that you're working with fit this particular theory or method? Is it comprehensive enough to cover the majority of clients that you may see given in this population? Is it parsimonious? In other words, parsimony is where this practitioner chooses the simplest explanation that fits the evidence. So in other words, what's the simplest way to accomplish what you're doing? That's having to do with parsimony. And then, is it testable and able to withstand scrutiny? In other words, if it's tested, does it have any efficacy or does it work based on your client experience? And again, you're asking the client, hopefully, how this is working with them. And again, the importance of eclecticism. There's pros and cons about eclecticism, but in social work, if you know the theories, if you know the methods, you can apply whichever ones seem to fit a particular client's situation in life. And that's what distinguished us for many years from mental health counselors, because we didn't just use a particular method with everybody, but we know of all these methods and we know which ones seem to fit based on our experience with clients most effectively. And a lot of times, again, it's a client's unique characteristics sometimes point to different a collection of these methods and models and how you develop your relationship with them that can be effective. So technical eclecticism is the application of procedures solely on the basis of their prior demonstrated efficacy. So this is evidence-based practice. You want to use various procedures that show that they've been successful. And then what are the common factors? These are based on the practitioner's assumption that all theories exert their effects through similar underlying processes. So the process, what is the process to get from A to B? Theoretical integration, here we have utilization of a range of theories based on the particular presenting issues of the client. Next, we look at agency characteristics that affect a practitioner's choices about theory to include. Most times when you're working in an agency, the supervisor's preferences in terms of treatment are probably going to be of great importance in terms of how you practice. Exposure to some theories but not others. In other words, certain agencies seem to embrace certain approaches versus not using others. The level of administrative support for professional development. The extent to which risk-taking by staff is encouraged. A lot of times no risk is encouraged, and other times people are willing to risk as they know your work. The agency's emphasis on program evaluation. And again, this is really critical and fits with what I'm talking about, Miller's 2 sheets that I'm having you download. When you ask the client or elicit their input in terms of the effectiveness of what you're doing with them. So that's also part of that relationship building as well. You want to have a relationship where the client feels comfortable telling you that you absolutely stunk that day and they got nothing from the encounter. And then you may want to begin to look at what are the cues while you're working with a particular client that suggest that nothing's getting through. And then you may want to ask before the end of the session, is this really working for you now? That sort of question. I mean, that's not the only one, but as an example. And then the client outcome research. How successful has this agency you're working with been with the clients? Is there a great recidivism rate, or is the evidence-based methods they're using actually working? Then moving now to the idea of critical thinking, which is purposeful, reasonable, goal-directed, and evaluative of its outcome. And this fits a lot with what Miller talked about in his deliberate practice ideas. The critical thinking is what happens before, during, and after you work with a client in a session. And I have an Einstein quote there, education is not the learning of facts, but the training of the mind to think. Again, critical thinking. The characteristics of the critical thinker are willingness to question one's basic assumptions about theory and practice. So questioning whether what you're using is working. I mean, if it's obvious that it's not working, then there's a need to begin to look at what other things might be effective. And certainly sharing with colleagues is an important element of this. Making an effort to work toward an elusive objectivity. ability to imagine and explore alternatives, understanding the importance of social and cultural context in human behavior. And this is critical because you'll encounter clients from many different cultural backgrounds, and having some notion that if something looks peculiar to you in your experience, it may be very normal for someone to experience that based on their cultural heritage and the place in which they live. The ability to distinguish between questions of fact and questions of value, and cautiousness when interfering or inferring causality or making generalizations. A lot of times, cause and effect is perhaps not the best way to try to construe or look at what's going on with the client, because sometimes one cannot clearly get what is the cause of a particular behavior because of a range of issues that may be present in the client's life space. And again, critical thinking benefits. It's a means of clarifying assumptions underlying one's work, increased accuracy in your decision making, shared understanding among practitioners and clients, guidance in clarifying the influences of one's values on practice. And then again, what would the cost be involved? It takes time and effort. Again, deliberate practice could be time consuming, but it certainly will improve over time your effectiveness as a practitioner. It requires a tolerance for doubt, may negatively affect one's self-worth when acknowledging mistakes. For instance, when you elicit from the client at the end of the session whether it worked or not and it was a dismal failure that day, rather than taking this personally, it's an opportunity, say, for one to improve. And so your deliberate practice between sessions would be to kind of construe what it was that didn't connect. Was the fact that you had not established a strong enough relationship where the client was comfortable disclosing the information you were trying to elicit? Was that the issue? And so how might you go about making the client experience more comfort in terms of being able to share that in the next session as an example? And it requires courage to try new things, to face what the clients may be sharing with you in order to enrich what it is in the client's life and to improve your practice. And then we will shift towards looking at implications for practice, or ethical implications, certainly. The use of practice methods that are evidence-based is certainly an ethical challenge. To inform clients of your duty to warn during the first session. In other words, you want to let them know that if they disclose certain things to you as a mandated reporter, you're going to have to report that information. And then to adhere to the requirements of confidentiality and certainly the ethical codes of the NASW in terms of our practice, because that is the main model that's used in the courts. Whether or not you belong to the NASW Code of Ethics is the social work code of ethics, and it's important to know that and have a really good handle on what its details are. Next, I want to kind of overlook the course rather quickly. I don't like the way the Walsh book is outlined because it jumps around. I think it's important when we're looking at something like psychotherapy or clinical practice that it comes from a long history of people over time who've given deep thought about how to approach these issues. And first it started with Sigmund Freud. So here I have some pictures of the founders. We have Anna Freud, who's Sigmund's daughter, who did some work with him over time. But then there's a grouping here of Freud with people who are his contemporaries. Otto Rank, who I happen to like a lot in terms of his work. He wrote a book called Art and Artist and had other important elements in terms of psychoanalysis. And then in the picture down here we have Carl Jung. We have Freud here. We have G. Stanley Hall, which is an interesting character in terms of his own research over time. Carl Jung, of course, my hero of the bunch. And then some other people who we may not know as well, but were at the time well known in the field. Certainly Alfred Adler is a major theorist at the time. Erik Erikson came later in terms of developmental theory, and Eric Berne with transactional analysis. Interestingly, Eric Berne, when I was in high school, had an office in Carmel, California, which wasn't a long distance from where I grew up, and was very renowned at the time in terms of his therapy. And I will share with you transactional analysis during the course of the semester because I think it's an important approach. Next, we move to what I call the GLORIA tapes. Although these three individuals did not mesh in terms of their therapeutic approach, we have Carl Rogers, who came from the more humanistic approach to therapy. In person-centered approach is what he developed. Then we have the rational emotive behavior therapy of Albert Ellis and Gestalt therapy of Fritz Perls. All of them encountered GLORIA during an hour session, and I have the tapes up on the site. I know it's an old tape because it's back from the 50s, or I'm sorry, from the 60s, but I think that it's important to see the masters doing their work, because these are foundational people that have a lot of implications on what is happening today in therapy. I know we hear a lot about cognitive behavioral, but that's not the whole potato, so to speak. There's a lot around that and a lot of other approaches that I think have been as effective, although not so much focus on controlling people's behavior, which really is a lot about what CBT has to do with, at least today, in managed care environment. The next we move to is to look at cognitive therapy, behavior therapy, cognitive behavior therapy. We look at such individuals as Pavlov, who dealt with dogs, I believe it was, the saliva kind of thing, then Skinner, Wolpe. Certainly Beck and Alice were contemporaries in terms of this approach. Beck's approach, as you see down below, he and his daughter, Judith Beck, is brilliant. I've attended some workshops that she's presented at national conferences. She's kind of sold me on some the efficacy of CBT, although I've never been a great fan of that alone. And then we have some other third-generation cognitive therapists, such as Hayes. Linehan has worked a lot with DBT and borderline personality disorder, and then Siegel. So we'll spend a significant time looking at cognitive behavior therapy. It'll be a week because of the limiting time we have to get through all of these through the semester. The next group we'll look at is the spiritual, existential, humanistic, transpersonal approaches. My hero of the 20th century certainly is Dr. Viktor Frankl, who developed logotherapy. Rollo May, another humanistic existentialist. Irvin Yalom, who's done a lot of work with groups. Stanislav Grof and his wife Christina developed this idea of spiritual emergency, which I will allude to briefly during the semester, but talk more about in my spirituality course in clinical practice. William James was a philosopher, but certainly impacted a number of these individuals, as did existentialist theorists. Abraham Maslow, of course, developed the hierarchy of need. Again, Carl Rogers was one of the humanistic individuals. I liked Roberto Assagioli, who developed psychosynthesis. Again, you don't hear a lot about psychosynthesis, but I think he was certainly a brilliant contributor to psychotherapy in the mid-century. Ken Wilber, again, Ken Wilber is sort of like a Renaissance man. Wilber is a philosopher. He's developed a theory of developmental psychology. He's looked at what he calls the holographic paradigm and developed integral theory. And his book Spectrum of Consciousness is interesting because it does include his psychological development theory. Again, a range of individuals, some of which you may not hear of after this class, but I think that some of these people are giants, I think, in terms of the field, and I wanted to tip my hat to them as we look at the overview and as we go through the semester. Next, we'll look at postmodern theories, solution-focused, narrative, and constructivist. I've collected into this grouping for the week that we reflect on that. Narrative therapy, certainly Epstein and White have had a significant impact on the development of that. Ensu Kimberg and Stephen DeShazer worked in Milwaukee developing solution-focused therapy. You'll find perhaps a couple of videos, particularly at least one with Ensu Kimberg on the site. Both are now deceased. And then Michael Hoyt is a contemporary person that runs around the Erickson Foundation workshops and meetings, who I've attended a couple of workshops that he's put forward, and he's a very effective practitioner. And then we have the founders of the Milan family therapy that fit within this constructivist narrative approach. We'll look at that as we go through the semester toward the end. Additional theories we will look at is the feminist empowerment, family systems, and crisis intervention theories. We have Betty Friedan back who was a feminist a leader in the field, as well as Gloria Steinem. These are people back in the 60s when people were when feminism was resurging and people were burning their bras, for instance. And then we have Bowen, who developed family systems, and Shirley Chisholm, again, a person who was nationally prominent and in the 60s and 70s, if I remember correctly. And then also, I tip my hat to Joan of Arc, one of the people in history that I tremendously admire. But she was burned at the stake, although she was a visionary mystic, and some people considered her a cross-dresser. Although I don't think that's the reason that, in chainmail there, that's kind of um, an interesting way to present. But historically, there have been women throughout history who have represented feminism at its best, and certainly Joan of Arc, I think, is one of the individuals who really was passionate about her country and her contribution. And then in the final week, we'll look at final weeks actually, we'll look at multicultural theory separately because it's an important element in terms of cultural competence and our awareness of various cultural elements and racial elements in terms of what clients bring with them to therapy and our understanding that. Certainly this is a critical part of your relationship building in your initial sessions of therapy. Motivational interviewing, which is a large practice currently, is something else that we will look at. I've uploaded the second edition of the book, although there's a third one now that's added material. But for your information on the site, you'll be able to access the second edition of Motivational Interviewing by Miller and Rolnick. The middle picture is from Fresno State off the internet, but I wanted to kind of show pieces of that's the multicultural picture. MI is the Miller and Rolnick, and then also I found this kind of humorous beer commercial guy on the internet. It said, "I don't always get my patients to stop drinking, but when I do, I use motivational interviewing." Just sort of some humor here at the end of the first week. I hope this has been helpful and best wishes in working through the semester.